Well, as you said, it's great to have new options, and now we have a number of different options. You know, in addition to obinutuzumab, this glycoengineered antibody, you know, we've had studies that have looked at idelalisib, ibrutinib, and you know, and combinations of both traditional and these newer agents. So I want to get to the question of sequencing as we think about, you know, patients who will have relapses, and of course the nature of these diseases is that we don't cure patients and that they have multiple relapses. So how do we you know, sort through the data, and let's talk about some of the combinations, like for example the combination of obinutuzumab with bendamustine, as you just talked about.
Right. Well, so a couple of things. First of all, I think in terms of thinking about second treatment after recurrences, it's important to keep in mind that we've now been able to identify groups of patients with follicular lymphoma that might behave in a little bit more aggressive way. We've been looking for clinical factors. There's the FLIPI-1 and the FLIPI-2 score that help us make predictions. There's recently a molecular analysis looking at a number of genes plus FLIPI. We helped to develop so I mean, those are important criteria, but there's an important paper that was published by Carla Casullo looking at one major risk factor, and that was recurrence of disease within a 24-month period. And there's some studies looking at 12 months, but it looks as though if you do treatment and the disease recurs relatively early, that's a group of patients that may not do as well with any of the sequences that we're talking about. And I think those are patients that one might at least begin thinking about either novel therapies, more novel therapies, or possibly transplant, either autologous or even allogeneic transplant in younger, fit patients. So I think we'll talk mostly then about patients that are recurring after a 24-month period. And in that group of patients, there was a study. Lori Sen did the so-called Catalan study. And that basically looked at obinutuzumab and bendamustine versus bendamustine alone in patients that were refractory. A significant number of those patients had already had bendamustine. So we're asking patients to get now not only 6 cycles of bendamustine, but now 12 cycles of bendamustine, which I think is problematic. I'm not sure. I have trouble getting 4 cycles of bendamustine in patients sometimes. So that's one thing. The other thing is, if this study were going to be, and that was randomized, so if this study were going to be positive for bendamustine alone without a CD20 antibody, I think it would be the first study that I'm aware of in B-cell malignancies where an antibody didn't improve the outcome. And so, you know, I think the data suggests that that's an active agent, but my caveat there, I'm not sure about the comparator. I have some problem with the comparator arm in that study. But I think it suggests that obinutuzumab and bendamustine is active agent. Now let me skip to idelalisib and ibrutinib. Certainly there are data looking at idelalisib with or without bendamustine and rituxan. Active agent, it's approved for refractory or recurrent follicular lymphoma. There was a Dear Doctor note that was written by the company, and FDA got very much involved in toxicity in that study, and patients were getting what looked like a higher incidence of either bacteremia or neutropenic fevers, and importantly CMV reactivation and pneumocystis. This is a group of patients that's been heavily treated. I think the data are just sorting out now, but I think there's the caution if we're going to use idelalisib, especially in patients that have had prior extensive therapy, is that they're immunosuppressed. T-cell function we haven't looked at. We've looked at T-cell numbers, and almost every patient that's had a course of bendamustine has T-cell counts, they're 100 or less. And so those are patients that we routinely put on PCP prophylaxis and antiviral prophylaxis and antifungal prophylaxis, actually, and monitor CMV status on a monthly basis. And that's what's now required by the FDA. So if we're going to look at idelalisib, that has to be with some caution, and number one, and at least in the lymphoma patients, and number two, the other toxicities are something that people should become comfortable with managing, the colitis and the pneumonitis that tends to occur. You know, I think those are some of the second and third line agents. One thing that that maybe we haven't talked about much, that historically has been active, is radioimmunotherapy. There are plenty of data, and we're still following patients 15, 16, 17 years out after one dose of Zevalin who are still in complete remission. So I think it's an agent that's been forgotten about a little bit, but I think it shouldn't be forgotten when we think about options for second and third line treatment for patients with follicular lymphoma.